Hello, hi. Once again, I'm Dr. Safia Zahir and I'm the surgical registrar who worked in Shalamar Hospital previously, but now I'm working in NHS. So I'm going to have a discussion about the Lugol iodine in the preoperative phases on Graves' disease. Well, is it an effective treatment? So we conducted a meta-analysis study. So, as we all know, that toxicosis is one of the endocrine condition, which with an incidence of 1 in 2,000 in European population and 1.2% in US population, and in general population it's 1 to 1.5%. And Graves' disease is among one of the most common thyrotoxicosis, approximately 80% in United States. It's usually treated with antithyroid drugs, which responds to 50% of the cases, radioactive iodine in cases where we can't give antithyroid drugs, and surgical treatment is the definite cure when other treatments fail. Now, the crucial part is in Graves' disease, the preparation, the preoperative preparation, especially when the patient is undergoing for total or subtotal thyroidectomy, to optimize that antithyroid medications and Lugol iodine is given. Historically, what used to happen, a standard practice of toxic Graves' disease was optimized with Lugol iodine, although the dosage usually varies globally. Nowadays, it is debatable since the introduction of beta blocker and thiuracil whether the Lugol iodine stands the same benefits as previously. I'm going to have a bit discussion about the background that Joseph Lugol was the one who first developed the Lugol iodine solution, and it contains of element of iodine, potassium iodide of 10% along with the distilled water. So he was a French physician who discovered it, and Lugol iodine has been given in patients when we are preparing for surgery in Graves' disease, as iodine has shown that it decreases the thyroid hormone levels and reduces the blood flow. In moving towards that, in forward in the history, in 1920, Plumer was the one who gave Lugol iodine to his patients, especially when they were exophthalmic goiter, and he found that the symptoms dramatically improved with reduction in the mortality rates and stage thyroid operations were no longer needed. Since then, it has been a standard treatment for preoperative preparation for thyroidectomy. As in recently, American Thyroid Association guidelines have moved forward, and they have assessed their guidelines and found that they recommended the use of Lugol iodine in preoperative phases, especially in urgent toxic conditions when they're allergic to antithyroid medication. They are still adherent to the historical preference practice, even if they have clearly mentioned in their guidelines that the efficacy of the treatment is not validated and it's all historical basis with low quality evidence. So, and the first meta-analysis was conducted by Tessa and colleagues in 2018, which was a systemic review, and they found that there is decrease in vascularity and blood flow when the patients are given with Lugol iodine, but they didn't found any difference in the complication rates, but their sample size was quite small in the published literature. So our aim is basically, as we endocrine surgeons want to see if the outcomes of the Lugol iodine is comparable as due to the recent advancement in beta blockers and thiuracil derivatives, and we compared the outcomes, especially in preoperative preparation for Graves' disease before the surgery with control studies who did not receive Lugol iodine, by adding a more recently large sample size control study which was conducted in 2020, and we reviewed the effect of Lugol iodine vascularity and the complication rates. So we conducted the meta-analysis, and the data was extracted from the databases from the time frame of 1985 to 2020, and Boolean operator methods were used. So we used the comparative control trials were included in the studies, and others were excluded. The single arm trial, multiple arm trials, management, previously radioiodine therapies, studies with no clear descriptions, qualitative studies, and studies with the size of less than 10 were excluded to avoid the confounding bias. The outcome analyzed was the typical thyroidectomy scale, thyroid volume and thyroid weight, mean blood flow, vascular density, estimate blood loss, and postoperative complications, along with the mean operative time. The outcomes were measured with quantitative variables. The randomized control trial was assessed. The quality of them were assessed through Cochrane's collaboration risk of bias tool, and the non-randomized control trial was assessed using the Robin-1 interventions assessment tool. And all of these data was analyzed using the RepMan software, and the outcomes were assessed using continuous and decomatous variables where applicable. We found 250 articles, in which 60 articles were reviewed for eligibility and 10 were selected, in which in these 10, 4 were randomized and 6 were non-randomized. And out of these 10, 2 were retrospective studies and the rest of them were prospective study. All of these studies were conducted on Graves' disease, toxic goiter, and hypothyroidism. We found that 6 of these studies studied on Lugol iodine solution, and 4 of them had potassium iodide, but none in the control group. And the duration of the studies, we found that 6 studies gave Lugol iodine for 10 days preoperatively, and 2 studies gave 7 days, and another further 2 studies gave 13 days. A total of 977 patients were included, in which 372 received Lugol iodine. In a randomized control trial, 67 received Lugol iodine, while 64 did not. And in non-randomized, 305 patients received the preparation preoperative. So the characteristics of the study and its intervention, the outcomes were analyzed into a tabulated form, and we found that these are the recent one, and Linder was the one who had the highest rate of sample size with 315 and 370 in non-Lugol and 125 in Lugol iodine solution were given, and they monitored the thyroid weight, complications, operative time, and hospital stay. The difficult thyroidectomy scale we found in 2 of the studies, in which 43 patients received preoperatively and 49 did not, and the pool results showed no significant difference in both of them. Randall et al. Mentioned that there is no difference in the thyroidectomy scale in terms of friability, mobility, size, and fibrosis. Interestingly, he found that there is an increase in vascularity in patients who did not receive potassium iodine, while on the other hand, Wallen et al. Found the similar results in the difficulty in surgery, but the mean operative time and blood flow were reduced in potassium iodide group. The thyroid weight was assessed in 3 studies, and they found that the thyroid weight favored more in terms of groups which did not receive Lugol iodine. Similarly, the thyroid volume was found to be increased in patients who did not, and patients who received Lugol iodine, thyroid volume was increased to 74 mils and 68 mils in patients who did not receive Lugol iodine. Now the thyroid vascularity, which is the most important aspect when we give thyroid and Lugol iodine, and was observed in 5 of the studies, and we assess the thyroid vascularity by the mean blood flow and the vascular density. The vascularity was assessed by the Doppler study and identified all the 4 pedicles and monitored the peak systolic and diastolic velocity, vessel diameter, and the blood flow, and found that there is a significant difference in patients who received Lugol iodine. Similarly, the mean blood flow was assessed by microvascular densities by the vessels with the number of areas covered with or without staining, and they found that there is an increase in the there is a decrease in the vascularity in patients who receive Lugol iodine as comparatively to non-Lugol iodine, making the p-value quite significant. Similarly, Hoag et al. Demonstrated that there was a 60% reduction in the mean blood flow pre to post Lugol iodine, with a reduction in serum vascular endothelial growth factors and interleukin-16 to 55 and 50% when he compared from pre and post. April in his study mentioned that there is a reduction in the mean blood flow with reduce in vascularity, and it's better to delineate with the reduction in the delineate the anatomy with the reduction in the intraoperative bleed. The estimated blood loss was also significant in patients who received Lugol iodine as comparatively to those who did not receive intraoperative preoperative Lugol iodine. However, the mean operative time, which was mentioned in 4 of the study, did not find any significant difference. However, Linder et al. Surprisingly found that there is an increase in the operative time in patients who received potassium iodide. The post-operative complications were comparable. Both the groups did not find any significant difference in the post-operative complications. Vocal cord paresis and hematoma, they both were not significant in both the groups. As our study has limitations, we assessed everything and we found that there is some limitations, especially there is variation in the strength and duration of the Lugol ID given in different study. Different regimes of iodine was given in different study. The severity of hypothyroidism was not mentioned, and the time frame in which the euthyroid was induced was also not mentioned. The duration of antithyroid medications which was given and what kind of treatment was given was not mentioned in any of these studies. Moreover, type of surgery performed varied between the studies, with the partial, subtotal, or total thyroidectomy making it a potential weakness for our meta-analysis. In conclusion, our meta-analysis shows that there is a vast reduction in the mean blood flow with decrease in vascular density, causing a decrease in angiogenesis in the gland. As a result, it eases the surgeon to perform the surgery. However, there is no difference in the post-operative outcome or operative time or difficulty in thyroidectomy scale. Now, there is a question that comes in that it is debatable if the use of Lugol iodine will be beneficial in the long term, especially when antithyroid medications can itself reduces the vascularity of the thyroid gland. So that's a question that needs to be thinking about. Thank you.